Okay, I'm going to record chapter 26, which talks about children and adolescents. And we did cover this material early on. I think it was on the psychosocial well-being, but this is the appropriate place for it to be under children and adolescents. So I'm going to um, I'm going to record it, and then again, like I said, it just be some information that I'm going to be re-emphasizing. And of course, some of the questions you will be coming from this chapter again. So as we talk about children and adolescents disorders, uh, these symptoms usually occur early on in adolescence or early childhood or adolescence. And we're going to be talking about some of the psychiatric disorders that we see in children. And they can occur earlier than the age of, 20, of nine, I'm sorry. However, but just remember that children with mental illness also meet the criteria for more than one diagnostic category. So meaning they can be diagnosed with multiple things, just like adults can. And also, when we're assessing our children and adolescents, we need to make sure that doing assessment for children focus on more than just their developmental stage. Because sometimes children they do not develop at the same stage, but that doesn't mean that they have a mental health disorder. So a thorough assessment of a child, we need to look at the holistic, looking at everything, what the presenting problem, the environment, also the and their mental health status assessment, physical exams. Also, again, we also take in consideration it just like we would do an adult. In the adolescence, we definitely need to be focusing in on, substance use, sexual activity, and then again, for those substance abuse, sexual activity could lead to self-harming behavior, and then also suicidal thoughts. So when we're assessing children and adolescents, we don't use the same assessment scale. I think we talked about that. When we assessing children, we need to do the method of how we collect that data is interviewing, testing, observing, and interacting. Again, history, we also need to engage the parent, the caregivers, whomever, and question answer about their life at home and school. Not only are we just going to focus on at home, but what's going on at school as well, and vice versa. Again, when we're doing an assessment, I think we talked about this early on. We can have the child like do a game or role play, drawing, using puppets, things like that for those kids that are unable to respond. So you can get them to respond by games and drawing and things like that. So it's very important that we observe the interaction of those children, uh, how they interact with caregivers, how they interact with their siblings. So we need to do a observation on their behavior. So that's some methods of how we collect data. And we talked about ID, intellectual disability. It can be anywhere from mild to profound. It also can be a result of hereditary Tay-Sachs disorder. Also, there's fragile X syndrome chromosome. There could be some alteration in the embryonic development. Down syndrome being an embryonic disorder, fetal alcohol syndrome, those children, babies that are born to the mothers being under the influence of alcohol, and then pregnancy or prenatal problem like fetal malnutrition, premature hypoxia, and then infection. So again, pregnancy problem, we know that could also the mom that's on substance could lead to some developmental intellectual disability. And then again, trauma. Children that have been traumatized, poisoning. So again, could also pose a child to some intellectual disability. Uh, in some cases, ID physical traits such as short stature, abnormal, those almond-shaped eyes can be apparent. Also, you can see those neurodevelopments there by looking at the child, their physical features. So we want to make sure we do a well screening on these kids and note any delay. Then again, they may have to be referred to a specialist. Blood and DNA testing, also brain scans could also help support the diagnoses. But sometimes we could, not always the case, doing those tests. Sometimes we may um, fail to meet the needs of those kids. But like the test may not be really accurate, so to speak. So again, we look at, like I said, if a child is what they should have developed at what age, since a 5-year old, they should be at this developmental stage, and they're not there. So we take that into consideration, but that doesn't mean that a child is intellectual disability, because everybody do not develop at the same time. But we do take that in consideration. Um, some of the things that we can implement with these children with those neurodevelopmental disorders: parent, family, and individual counseling, appropriate school. Now, those kids that have the intellectual disability, they have IEP plans to meet their needs. The Federal Individual Disability Act. Again, it's important, it's mandated that we identify those children and develop a plan, an individualized plan. Occupational behavior therapists also, and then again, medication could be those clients that have not developed. And some communication disorders also, language disorders, where children they may not speak fluently. They again speech, their sounds, and then stuttering, and then they may have some social communication disorders. So we need to assess these kids again and note there are any abnormalities, any delay. Speech therapist would be the person to refer to. And then, of course, most schools have school psychologists on board. And so we got to make sure that these clients, we refer them, and early intervention is going to be the key. So these clients definitely going to need some supportive counseling as well. So early interventions is going to be the key. Autism. Again, it's a deficit. These clients have a deficit in their social and communication activity. They repeat behaviors. I think I've told you guys in class, my little niece, she repetitive. She'll walk in, when she walks in, she'll go straight to the living room. Every time she comes into her grandmother's house, so she repeats those behaviors over and over again. They have interest in their own. They like to play alone. Again, so again, early intervention is going to be the key for this disorder as well. They go through different levels. So again, it's very noticeable. They have some social deficit, meaning they like to play alone. They don't like to be, interact with other children or anybody. Then their speech is delayed. Sometimes it may take them several years before they can talk, and some don't talk, but some of them do talk. So again, verbal and nonverbal social communication skills. Again, that's level 2, and then level 3. Again, they have severe social deficit. They are again limited communication. They may or may not speak. So again, they just go through different stages. So as far as when assessing those kids with autism, again, we need to again observe their social and emotional deficit. Do they bond with the parents? Do they most of the time they don't like to be cuddled. Again, I think I told you guys, my niece at some point I knew at about 8 months that she had autism, because that eye contact, she didn't give good eye contact at all. She didn't like to bond. So now again, they lack interest with their peers. Like I said, they do not like to play with children. So again, their communication is delayed. Like I said, they have rigid routines. They sticking to the routine. They have ritualistic behavior. They do the same thing over and over again. So you can notice that in children that they like to play alone. They like to play with games. Electronics is what they really like. They like laptops and iPads and things like that. And they love to play along. When they get an interest in something, that's what they're interested in. Okay, so they are diagnosed between the ages of 2 and 3 years of age. And again, once they are diagnosed, early intervention is going to be the key. They are usually diagnosed by the child psychiatrist or either developmental pediatrician or pediatric neurologist. So, and as I said, early diagnosis and intervention is going to be, these kids will have good prognosis. Um, and again, they also need to be treated. The implementation by a multidisciplinary team, meaning they need speech therapists on their team. They need occupational therapists, because a lot of times they have problem with stemming behaviors, and then they need physical therapy to help with their strength and coordination. And I said my niece, she would just run and jump and fall. Coordination was very poor. They need nurse practitioners, psychiatrists, and then again in school, They need tutoring. They need smaller classroom environment because again, safety. They like to do rigorous activities, so they're going to be at risk for injuries. I think when she was maybe a year old, maybe she fell out of the bed and dislocated her shoulder because they like to jump around and play. So she fell out of the bed at that age. Then again, the next one is ADHD. We've already talked about that again. These individuals have problem concentrating. They make careless mistakes. They have a problem of focusing. They easily distracted. These are the type of kids that get really, they're smart, but they get really bored in school. And a lot of time they diagnose these children with intellectual disability, but when they master tasks, they want to move on to something else, okay? And then again, they don't want to. They're misplaced items and things like they just tend to be messy because they're just kind of like all over the place. Be very fidget. They run and climb and jump. Also, they interrupt. They talk a lot, you know. And so again, these kids also they are risk at risk for injury as well. So again, we need to notice that. And like I said, they don't pay attention, and they jump up out of their seat. They do inappropriate things, inconsistent. They go ahead and do an assignment. It's real messy. They want to go ahead and get it done, really quick. So because their attention span is very short. So again, so school nurse may see a student sent to the office repeatedly disruptive behavior, like I said, because they get bored really quick. They may have some interest, they may sit up there in school and scratch themselves. You have to watch them with objects. They may to kind of cut themselves, or they'll fall, if they run. So again, have some of the similar personality like your autistic children. So again, these clients they need to be treated. Again, early intervention is going to be again psychiatrists uh, will make the diagnosis. There's a questionnaire. It's like the Vanderbilt assessment scale could be used to identify children with ADHD, and it also helps in measuring their progress with treatment. So that scale called the Vanderbilt assessment scale, which again is used to identify children with ADHD. So again, behavior modification would be some intervention which could be put in place. Parent training as well. These kids have to be accommodated at school. And so again, there's some medication, pharmacological medicine that we could be used to address their inattention and hyperactive and impulsive disorder. Ritalin years ago was a drug of choice, but now instead of they try to treat the children with counseling I'm sorry, cognitive behavior intervention, but sometimes it doesn't work. Cognitive behavior therapy rather, and again they have to resort to medicine. So these kids, there are some other special learning disorder. We talked about dyslexia, dyscalculia. These are reading and written expression and math. They have a deficit in these skills. Um, However, we would make the assessment, diagnose, and then again, a thorough diagnosis is going to be very important for these children because again, they need a learning environment to be implemented that's be conducive to their needs also. Motor disorder, we talked about that already. It's a developmental coordination disorder. With motor disorders, these clients are very clumsy. They have slowness. They have difficulty with their handwriting or riding a bike. Um, Again, Tourette disorders, we talked about that client with those motor or vocal tic, where they kind of like I was telling y'all in class about this guy, this renowned speaker that I thought it was a something going on with the sound system, but actually this client is a renowned speaker. Talked about his you know past, about how he was bullied at school and how he maintained and finished high school and went on into college, and now he's a renowned speaker. It's embarrassing for those individuals with TIC. Very embarrassing. But again, they need to be diagnosed early on, and then get on. There's some medication that they are placed on for tremors and the TIC, and the comprehensive behavior interventions also for TIC. There's intervention specific for those clients. They need physical therapy and occupational therapy because there's a delay again in their even just tying their shoes because they're twitching so bad. Their motor skills are delayed rather, So again, OT and PT would be very beneficial for this population as well. And I already talked about bipolar, how it can impact children and adolescents. So we've already talked about that. So again, you see, and as I mentioned earlier, you see depression in children, uh, adolescents, as just as you see those in the older population. We and anxiety disorders, again, we kind of hit on that as well. Separation anxiety is when again children when they're being separated from their parents. You see this a lot when children getting ready to go to school for the first time, daycare or whatever. So they have that separation anxiety. Um, and then selective mutism. This is where a child fails to speak. They consistently failure to speak in situations where speaking is an expectation. They're able to speak, but then again, they embarrassed. They may have problems stuttering. So instead of being embarrassed, they just decide not to speak, and it's called selective mutism. And then they know they could be in another environment where they will speak. And I think I shared the example where this young lady was in a nursing home, and they alleged that she couldn't talk. And when I discovered that she liked pineapples, I gave her pineapple, and she spoke that day. And when she realized that she was speaking, she shut it down again, so she stopped talking. However, so that's selective mutism. Specific phobias in children, again, sometimes children they fear the dark. They feel like they'll go to bed, the monster's gonna get you. So that's the worst thing we can do with children because they have specific phobias and it scare them to death. And then costume characters, they're afraid of that. I was just told that an adult, uh, however, that I didn't know. I know the adult just recently afraid of school mascots. They're scared of costumes, and like you gotta be kidding. But I guess what? Everybody has their own phobia, so we can't. And injections, that was a phobia of childhood that I like today. I do not like injection. I tell everybody that I can stick all day, but I have a phobia of needles, and no one would believe it being that I'm a nurse, but I do. Being around water. Some children have a problem being around water and certain animals. So again, we don't want to terrorize those students by, making them more anxious or more increasing anxiety more by forcing them to come on, just touch it. We don't want to do that because again, it can really escalate to a very serious panic attack. So be cautious about that. So when we assessing those children with anxiety again, uh, ask questions, observe. The Spence Children Anxiety Scale or the Hamilton Anxiety Scale is widely used that we use to assess those children with anxiety. So, how do we intervene? Supportive therapy, cognitive behavior therapy, family, relaxation, and guided imagery. And also, we want books that address separation anxiety. And then again, there are SSRIs, beta blockers that can be used as well for an antihistamine to help with the anxiety disorders. And I will share those medications specifically that you need to remember. OCD, we've talked about that. We see this a lot in children as well, and obsessive compulsive disorders, and then some disorders that's related to obsessive compulsive. I'm sorry. And we talked about the trichotillomania, where constant twisting and pulling out their hair. Uh, um, Again, that's trichotillomania, and then excoriation disorder. That's where children kind of pick at their skin. They prick, they pull, they'll bite their nails down to, and then sometimes they'll prick under that skin. And that could lead to infection, and biting nails could lead to infection. So that's excoriation disorder. So again, cognitive behavior is really good for this population as well. Uh, Studies show that over-the-counter supplements could be helpful in reducing the skin picking disorders. Okay. Let's see. Reactive attachment disorder. Again, this is for children. They are emotionally withdrawn. They rarely seek comfort or responding to comforting. So again, that's called reactive. But they don't They have a pattern where they emotionally withdrawn. Usually they have a limited affect, flat affect. They usually irritable, sad, fearful, and then they have minimal social response. So they don't like to be around anybody either. So again, you see this a lot too, reactive attachment disorder with inconsistent caregivers or inconsistent care, living in foster homes or orphanage. Again, they have that reattachment disorder because of the fact that they don't know their families, so they've been detached from their families. Okay, and we talked about trauma and stress disorders as well. It resembles autism, depression, or disruptive mood disorders. Again, similar to those. However, it's related to trauma. They have stress as a result of trauma. So again, um, we see this a lot also in children. And we also talked about some feeding disorders, pica. Y'all remember that? Non-food substances. And then rumination. The client will chew their food, they'll spit it out, and then they'll rechew it and they'll re-swallow it. So that's rumination. And then avoidance, restricted food intake disorder. This is where they don't eat. Persistent failure to meet their nutritional need and energy. So these are feeding some examples of feeding and eating disorders. So we want to assess these findings, and then again, we try to get them in therapy so they'll kind of retrain from those behaviors. Family needs to be involved with those feeding disorders. Of course, we need to keep monitor the client weight and their nutritional status. Give them foods that their favorite foods that they really like, and may have to give some nutritional supplements. And also their medication that can increase their appetites. Then again, it's usually if they have these eating disorders, if they are depressed, they may have to be on a SSRI, SNRI, antidepressant to stop the compulsive behavior. So I've seen that also in several clients. Then we have elimination disorder, enuresis, where they repeatedly voiding of urine into the bed. They wet the bed. They may be involuntary or intentional. Sometimes the kids don't like to get up, or they'll drink a lot before they go to bed. So incorporesis, I'm sorry, they repeated passes of feces into inappropriate spaces, such as in their clothes on the floor. It could be intentionally, it could be involuntarily. It's considered normal until they're 4 years old. I've known children that they will know when they have to use the bathroom. They're of age, but they'll go around get in the closet behind the door, um, and use the bathroom, or they're intentionally using on themselves or unintentionally. So again, we again, um, it could be those eliminations order could be due to poor appetites, or again, like I said, they may not they're in reason they are too lazy to get up, but they just don't want to get up at night. But it could be something cognitively going on with these kids. Okay. And this talks about which child is most likely to benefit from cognitive behavior intervention therapy. And it's going to be a 12-year-old boy with Tourette syndrome. Okay, and then disruptive, oppositional, defiant. Again, usually um, these children they usually have behavior problems at school. Again, they goes beyond the normal limits testing of typical children. So again, this is something that we see a lot. Like I said, and why would a child have be defiant? It could be something that's adverse, a childhood event. So again, we need to go back and assess, what happened in the child's childhood, and also same thing with conduct behaviors. Uh, Again, usually we got to get to the cause of the problem. Those children that have a lot of problem at school, usually it probably usually it could, usually normally it's something that has gone on with their child in an environment. Could be they've been molested or neglected or whatever. So we need to get the parents involved. Also, again, we need to get them in therapy. Try to determine because usually they with or they could have, ADHD, and in conjunction with the conduct or uh, ODD. So again, we need to determine the cause of the problem. And as we're taking care of the clients, again, these are the several therapies that could be offered: group, milieu therapy, parental, behavior modification, and then it could get to the point where these clients may become, they could have, have to go on restraints and seclusion as well. So again, it just goes back to what is going on in the child's life.